speaker today in the introductory session on methods in biomedicine is a certified pathologist. Dr. Krishna Tangella here works, his day job is as a pathologist. So he's investigating blood samples, biopsies, as they come from the hospital. So he is with the Provena Hospital, or Provena Medical Center. He's the director of the medical lab at Provena and I think several other labs. So this is great for us to see, for you guys. I'm sure some of you have not seen how actually pathology is done in real life. And hopefully you'll find some room for improvement with new technology. So thank you very much, Krishna.
Thank you. Thank you, Gabby. You had a great lecture by Peter Wang, and he's awesome. What I'm going to be talking to you today will be a little bit about pathology. The reason why it's important to talk about pathology, especially a lot of you who are probably interested in research, and especially the biomedical research, is because pathology is a very fertile ground for research. There's a tremendous amount of specimens, as you want to call it, and materials, and clinical scenarios that while interacting with a pathologist, you can get your questions answered. So I do have a lot of slides. I do have a very limited time, but the plan is I'll stick around and have lunch with you folks. If you have any questions, we'll continue the discussion. If you don't go through the slides, that's okay. But the point I want to make is I want to go slow and get you all a little bit of take-home messages rather than cramming up 70 slides in half an hour and not taking anything home. A pathologist is a diagnostician. I diagnose diseases when the surgeon takes out a tissue from the body. It gets sent to the lab. It gets processed in the lab, and slides get made. I look under the microscope, and then I diagnose what it is. A pathologist not only diagnoses what kind of tumor it is, but a pathologist now is diagnosing how bad is the tumor, what are the drugs one can use against the tumor for treatment, and also give you a lot of prognostic information, is basically how bad the tumor is. Okay? So among other things, a pathologist does that. The other role that a pathologist plays is they manage the laboratory in a hospital. There is a lab in the hospital. Somebody has to make sure that the results that are being issued are reliable and accurate. So there are a lot of technical machines that do a lot of work. Somebody has to be supervising them, making sure that clinically accurate, right? So that's what a pathologist also does. The pathologist also helps out in blood transfusion. Anytime somebody needs a blood product, such as red cells, platelets, or any other type of blood component, a pathologist oversees the process also. So it's a field that is very wide and extensive, but a very little portion of my work is actually autopsies. The one you see program called CSIs, I do very little of that work. In fact, CSIs look very attractive when you watch it for half an hour, 45 minutes episodes, but they are very boring in real life. Okay, so life doesn't work that way. Okay, so anyway, what I'm going to do is I hope to have a two-way discussion. I hope to have a two-way discussion, slowly but steadily, and I want you to ask me questions. Okay, I want you to ask me questions about what I'm trying to show, and basically whatever you wanted to ask a pathologist, right? You can. This is a chance. Okay, so what happens is that the specimens get sent to the lab in little bottles like that. Okay, they get sent, and then we open up the bottles to get the specimen out. And as you can see there's an example of a gallbladder. Somebody who has a gallbladder pain, they take the gallbladder out, they send it to us, make sure that there's nothing wrong with the gallbladder or what is wrong with the gallbladder. Just a I'm giving you one specific example here, okay? So what the process of looking at the specimen macroscopically or visually is called grossing in, okay? It's not because it's gross, okay, but it's called grossing in. So if you hear a pathologist says that I'm grossing in right now, it means that they're looking at the specimen macroscopically, not micro, macroscopically. Here is an example of, we get a variety of specimens, right? Here's an example of a uterus, okay? So here is the body of the uterus, and there's what is attached to the uterus? Can you tell me? Fallopian tubes, and attached to the fallopian tubes is what? Ovaries. So there are two ovaries, and then the fallopian tube, and then the uterus, and this is the body. This is the fundus. The body is here, and then the cervix is at the other end. So just to give you an example of the kind of specimens that we get. After we get the specimen, we open it up or cut it up in a systematic fashion according to certain protocols. We take specific tissues where we think the diagnostic material is or diagnostic areas are. We put a little bit of tissues in what we call this white containers called cassettes. These are called cassettes. And these tissue pieces are called sections. So what I've taken is I put sections of the representative areas of pathology in cassettes. After it's put into these cassettes, okay, some of them are big specimens like this, right? Some of them are very small. This is one cassette, and this, you see this tissue here? It's a very small tissue. So somebody undergoes a colonoscopy, and the doctor endoscopically sees a little polyp. They take the polyp out, sends it in a little container, and the container gets processed by the lab, and the tissue is taken out and put it between the sponges. The reason why we use sponges is because you see these little holes here. You don't want the tissue to run away in these little holes, right? So you put a sponge here and then put a sponge on the top, and then you close it and you process it. You will get a chance to go to the hospital laboratory where you will see the way how specimens are grossed in, where they are processed, where they are cut to be made into slides. Okay? So after the specimen is processed, it takes about 8 to 12 hours to process in a machine where it goes through multiple steps. It comes out, and what the techs do is they embed in a paraffin blocks. Okay? Once they embed in a paraffin blocks, then a technician again cuts them at 3 to 4 micron sections onto a glass slide. At this point, the slides are unstained. Then they go through a stainer process called H&E staining, hematoxylin and eosin staining. After this goes through the staining process, then the slides get cover slipped with the patient name and the identity of all the material, and goes to the pathologist, and the pathologist actually looks under the microscope and makes a diagnosis. So did I go through each step? Okay. So sometimes what happens is that a surgeon in the operating room opens up a belly for, say for abdominal pain example, and sees some tissue there that is not supposed to be there. Now, he cannot wait 12 hours or 24 hours for a diagnosis. He needs to know what the tissue is, what the diagnosis is, so he or she can do something right then. Correct? So they want an immediate answer at that point. One of the ways to answer that question is for the surgeon to request what we call frozen section. A frozen section is a process by which a surgeon requests a pathologist to give immediate diagnosis. Immediate meaning within 20 minutes. That's what immediate means, okay? immediate diagnosis. So what we do is we get the specimen in the lab and we put a little bit of tissue tech. It's a material around the tissue, and then we freeze it to minus 30 degrees centigrade. Okay? After we freeze it, it becomes a block, a frozen block at that point. Then this is called a microtome, and you can see these two blocks here, frozen blocks, and then we take sections of these blocks right away. And after you take the sections of these slides, or rather the block, they get stained. I look at it right away, and within 20 minutes I call them up and tell them it's cancer or no cancer, or whatever the question the surgeon is asking. It can be very stressful because we are working very fast, and the patient is actually under anesthesia with a belly open, and you're basically holding up the patient. Every minute the patient is under anesthesia, it increases the patient's risk. Okay? You would not like to have a patient under anesthesia longer than that's necessary. So that was that. So after these tissues are processed, they are embedded into what's called a paraffin blocks. This is what a paraffin blocks looks like. Okay? We get hundreds and hundreds of them every day. After it gets, next morning, it gets cut by this machine called microtome. Okay? And this machine is actually automated machine where you put the block in here, and then you kind of spin the wheel around, and at 3 microns the sections keep coming out. Here is how the sections come out. Okay? As the sections come out, these are 3 microns, okay? You can see the wax around it. And then what they do is, let's go back up here. What they do is they put it onto a water bath and then spread the tissue around and take a glass slide and then take a section of the slide, section of this tissue onto the slide, and then dry it and then stain it and give it to us. You will see this slides how they are prepared hopefully when you come on the tour. I think it's on Friday. Any questions so far on how the tissue is processed and what happens to the tissue? Yeah.
If you want to look at surface biomarkers like integrins and things like that after the tissue has been processed, you want to do like antibody staining or things like that. Are these biomarkers preserved after this process?
Yes. So after the sections are made and H&E stains are done, we only look at 3 microns, right? See this tissue here? There's a lot of tissue that's pending in the block. If I'm able to make a diagnosis based upon this ribbon of tissue here on H&E, then what happens is that we save the slide, I dictate my note or dictate my diagnosis, and this block, paraffin block, gets saved. It's called archived. So we archive the blocks. Generally, according to the American regulations, we keep this block, we are supposed to keep this block for 7 years. The slide, we are supposed to keep for 10 years. Okay? Now the interesting question you ask is, if I'm not able to make a diagnosis, or I need to give more information about the tumor, such as I pointed out, there could be a lung cancer. I can do a lot of markers on the lung cancer, whether you can use this drug or that drug, right? I can look for those receptors on the tumor. And we can do something called immunohistochemical stains, where we use antibodies to tag that epitope of protein and see if it is present or absent. If it is present, then you can use a certain treatment. If it is absent, then you use a certain treatment. Okay, so yeah, that all that immunohistochemical stains and special stains, antibody workup comes later.
Do your technicians have to wear masks when they're doing this?
So, no, they don't have to wear masks because the material, when we get the tissue from the operating room, if it is not for frozen section, if it is for frozen section, it comes fresh. If it is not for frozen section, then it comes in formalin. Formalin is an agent that kills pretty much all the microorganisms. Okay? All infectious diseases are killed except prion disease. You know, you have heard of prion disease? Like mad cow disease? It's a prion disease. Formalin doesn't kill that. We have to use a special process to kill that. But if you don't suspect it, then we don't have to take additional precautions. So you do not need to take, a mask. But the question you ask is very good, and this one is the answer, I would say. During frozen section, the tissue is fresh. It's freshly frozen. And if it is from a lung, a portion of lung, and the doctor don't know if it is tuberculosis or if it is a fungal infection, then yes, at that point, this is infectious because it can aerosol, right? So this is infectious. At that point, yes, you can wear a mask. But usually what happens is that this cryostat has a little bit of cover on it. When you cut it, the risk is low. But yes, that you can wear a mask at that point. Yes. Especially if the technician, I would say if it is high risk because of lower immune system or currently pregnant, we tell them to wear a mask and then do this procedure. After the procedure is done, if we suspect it was an infectious etiology here, we decontaminate the cryostat. There is a decontamination process on the cryostat. We press the button. It takes a while to do it, and that's how it gets decontaminated for the next case. Yeah. Somebody else had a question? Anybody else has a question? Yeah.
This may sound a bit silly, but at this point you're looking at dead tissue and dead cells, right? All the analysis that you do is essentially on. So what impact does that have on what you can learn from it, as opposed to what you would like to know, which is something about the living tissue? Is that a big difference? I'm not in the biology.
No, it's okay. It's okay.
So again,
can you explain? That's all right. No, it's a wonderful question, but can you explain it to me one more time? What do you?
So
Are there artifacts in the tissue preparation that affect the properties of the living tissue, right?
yes, pretty much. I mean, ideally, you would like to know something about the living tissue.
Right.
But because of the process, you have to do the analysis. It's not in vivo; it's ex vivo. So you do it on
right. It's a very good question you ask. It's a very good question to ask. And the answer to the question is, yes, it does matter sometimes. This is a perfect example. When you take a tissue, a live tissue, and you put it in -30, what do you think is going to happen to the tissue? It's going to go through freezing. Freezing is not a normal physiological mechanism. We don't go. If you go to -30 and let the skin go to -30, it's going to you get gangrene, right? You get cold burns, right? So, same thing. This tissue will undergo this rapid crystallization, physically, right? Crystallization, causing artifacts in the tissue. And that is a problem with a frozen section. That's why we don't freeze all the tissue. Why do we wait for 24 hours? We could take if this was such a wonderful technique, then we'll take all the fresh tissues, we just cut it up, frozen section, 20 minutes later we give the diagnosis, everybody's happy, right? What we get here, something called freeze artifact, that makes the histology a lot more difficult.
So,
yes?
The other night we had a presentation about photoacoustic tomography, and it seems like that technology would be very useful for this application. where they're getting immediate imaging results, and you can tell the characteristics of the tissue and cells and things in color in real time for live tissues.
What is the technique, Gabby?
It's
Are you gonna give?
Okay.
Photoacoustic tomography.
Okay.
The professor Wang at Washington University gave this
Okay.
presentation about the recent developments in photoacoustic tomography that seems like, and maybe I missed something, but it seems like what you're doing with the frozen section, he can do with live tissues in color.
So, okay.
So this is a very recent development.
Sure. So basically when you talk about photoacoustics, you're talking about looking at a tissue and putting sound waves into the tissue and looking the echogenic characteristic of the tissue and then creating a map, like ultrasound, right? Yeah. The problem with that is the resolution. If you take this, if I have an ultrasound in a transducer here and if I do it, the sound goes down and the architectural echogenic area comes back and I construct an image, right? That image is not as detailed, as this H&E where we can go to 3-4 microns, right?
Well, in the talk, they showed that they are approaching that limit.
Oh,
Now,
then I'm in trouble. I need to learn what it is before somebody else does it, Yes. So that's good. Yeah, I've heard of similar techniques.
It will be a while before it goes to click.
Yes. Yeah.
There are
Hopefully I'll retire by then.
that are trying to do the same thing in my lab, working with Dr. Tangella.
Yeah.
Yeah.
Plus with photography, you're limited by things that actually explode enough for you to have a signal. And if you have a region that has a lot of, say, hemoglobin, then you're going to have a lot of other lower absorbing areas that don't really give you a signal. So depending on what you're looking at as far as pathology is concerned, you may or may not be able to use it. If you're looking at, say, architecture in terms of blood vessels, that might be a great technique to use as opposed to doing pathology. But if you're looking at membrane structures, then you may not even be in a good position.
Correct. Okay. So at this point, this is the best we can do. And this has been for last 150 years or 200 years and still standard of care right now. So a lot of summer schools are being done, but nothing has changed in this technique yet, So hopefully 20 years from now, one of you will have an idea and kind of make sure you include me so I can retire with you. So, any other questions? Okay. So what I'm going to do is, I have 15 minutes. I'll talk to you about lung cancer, and just to give you a little bit of snippet of what some of you may be interested in tumor biology. Lung cancer is a common cancer, and I'll just give you a little bit of a flavor of pathology so you can understand what happens in pathology. Okay? So I told you the techniques in the lab that we use, some basic principles of, and now I'm going to talk about one disease. And if I have time, I'll talk to you about red cells and what kind of abnormalities one can look at red cells. The idea of this presentation is to get your thought process going as to what are the possibilities that you can implement your physics and into biophysics, right? I mean the techniques that you, physical techniques that you have, that you can use in tissues. So now you know that the pathologist is a very important person for research. Number two, there are a lot of materials that are stored in the lab for a long periods of time. If you're looking for pancreatic cancer, it's there. If you're looking for endocervical cancer or endometrial cancer, it's there. If you're looking for prostate cancer, it's there. You have a lot of tumors. Then, if you're doing a protocol and you want to work with a fresh tissue, not the processed tissue, then we can request the tissue to be sent down fresh from the surgeon, from the operating room, we can take a little bit of it and give it for research too. Those protocols also exist. Okay? And of course, there's a lot of immunohistochemical stains and other techniques that one can do. I did not go into molecular techniques that Dr. Wang pointed out. Pathologists also are involved in molecular pathology, where we do PCR, polymerase chain reaction. We do FISH analysis, which is fluorescent in situ hybridization. So these are all the molecular techniques that one can use to characterize a disease process. So lung cancer, I'm going to go through a little fast. Obviously, it's over 200,000 cases in 2008 per year. And I can see here, for some reason, we know why, actually, if you see the incidence of cancer deaths in females due to lung cancer is just going up. And this is because in 1970, there was a huge movement in women to start smoking.
Start smoking?
Yes. The Slims, remember the Slims that came out in 70s? So it was a big deal in the 70s. You don't know. 70s was a long, long time ago, you know. Gabby will know all about it. He just lived that world, you know. Yeah, exactly. You're being taped, Gabby. So that's what happened. So it takes about 10 to 20 years after smoking for lung cancers to appear. So if you look at it, 1970s, 1980s, they have been smoking a lot. So, 2000, 2010s, the cancer rates are going to go up. That's why the incidence of heart attacks in women is also going up, because smoking is a risk factor for heart disease. Am I going too fast, too slow? You like what you're hearing? Okay. On other hand, if you look at males, it started dropping a little bit. Okay? The reason why it started dropping a little bit is that there was an anti-smoking cessation campaign with all the lawsuits against tobacco companies that started happening 15, 20 years ago. So these rates were very high to begin with, so it didn't take long for the rates to drop either. Okay, so that's one of the reasons. So if you look at it, if you have colon, breast, or prostate cancer, from 1960 to 1996, so it's about 35 years, right? So in 35 years, you can see that 5-year survival for somebody who was diagnosed with prostate cancer was only half of them lived in 5 years in 1960s. In 1996, 100% of them lived. Breast cancer, from 63% of them lived to 88%. Look at colon, from 43% to 65%. So whatever we have done in colon, breast, and prostate because of intellectual minds like you has made a progress and a difference to mankind. Okay? But unfortunately, we are not doing too well with lung. We have new therapies, we have new techniques to diagnose lung cancers, but somehow we are not being able to decrease this. Once they're diagnosed, yes, only 16% of them live after 5 years. After all these years, yes. Population numbers who have cancers? Yeah, so prostate is very high. So let me put you an example. Just give you an example. A rough estimate is 80% of the individuals who are 80 years, 80% of the individuals who are 80 years and above have prostate cancer. That's a lot. So if you live long enough, you will get a prostate cancer. But the dictum is, if you're diagnosed with a prostate cancer, it's more likely that you will die with prostate cancer rather than die of prostate cancer. So prostate cancer doesn't kill you.
And the other thing this doesn't take into consideration is the quality of life. Someone might be alive after 5 years, but if you go out of pain or hospice, barely hanging on by a thread.
Right. So you're very good. So quality of life is very important. But usually when we say 5-year survival, given prostate, breast, and colon, the quality of life is pretty good. Okay? Lung also. I mean, the people who die in 5 years, right? What we have been able to do is that even though we have not been able to save them from living longer, but we do know that the 5 years within which they're going to die are more comfortable 5 years. They have a better performance. Okay? So we get what, 200,000 cases of new lung cancer, right? I mean, that's not a lot, but it kills quite a bit. So just give you a little flavor. Lung cancer doesn't mean it's only one type. Cancer doesn't mean it's one type. Cancer is a very common term loosely applied to a lesion which grows in the body without body's control. Okay, and it has the ability to metastasize. That's cancer. Okay? Cancer, causes of cancer are varied. Some we understand, some we don't. Some cancers are caused by infections. For example, in HIV individuals, somebody who has AIDS, you get Kaposi's sarcoma. Kaposi's sarcoma is induced by a virus. Okay, human herpes virus 8. Some cancers are induced by chemicals. So certain industry, for example, shipyard workers, somebody who worked in where there is high amount of asbestos can get mesothelioma. Some are genetic. We have 18-year-olds and 19-year-olds getting breast cancer and ovarian cancer because they are genetically predisposed because of a mutation in a gene called BRCA, breast cancer 1 gene. Okay? So it's important to understand that cancer is not a single disease. It is a disease of various etiology. And because it is a disease of various etiologies, the treatment of cancer cannot be one. The treatment for cancer has to be different based upon the different etiologies. Okay? Got it? So, lung cancer doesn't mean it's just lung cancer. Lung cancers are different types. One of them is called bronchogenic carcinoma, which is actually a adenocarcinoma where it starts making glands. I'll show you some pictures. But here is an X-ray. The reason why lung cancer is bad also is unlike cervical cancer. Cervical cancer used to cause a pretty high death rate. Now cervical cancer is almost, death due to cervical cancer is very, very low. Why is that? Why is the incidence of cervical cancer gone, or rather the deaths due to cervical cancer gone down significantly?
Early diagnosis and
annual
exams.
Pap smears. Yeah. What's a pap smear? It's a screening exam, right? So screening exams help. If you have a good screening exam, it helps in prevent, rather catching it early and stopping it from killing you. Breast, for example, you have mammograms, right? So you got to tell your parents if they are in their 40s to go and get a mammograms, okay? Colon cancers don't kill as much because of a screening exam called colonoscopies, okay? Lung cancers, what is the screening exam for a lung cancer? Is there one? I'm asking you a question, you ask me a question?
Right.
No, there's not. You cannot get a CT scan or a chest X-ray, every 2 years and see if there's a lung cancer, right? I mean, there's no recommended screening exam for lung cancer. And that's a problem. And that's one of the reasons why when it comes, by the time we get it, it's kind of too late. If we are able to catch it really, really early on, maybe that's due to lung cancer will decrease tremendously too. And you can come up with a technique where you can diagnose lung cancers early without putting the patients through a lot of radiation and other discomfort, right? That's a thought process. So here is an example of a lung cancer. See this big mass here on X-ray. This is a normal X-ray. Okay? And this is a 5 centimeter mass. Okay? Not all lung cancers are so easy to diagnose. Some of them are really, 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 really small and tiny, So this is again another cancer here. You see this cancer, how big it is? It's a huge cancer. All this white area here. So this again, look at that. Lung cancers, both lungs being affected on a chest X-ray. This is a CT scan where you can see the lung cancer here bilaterally. In fact, it looks like pneumonia. Pneumonia would look like, this is what pneumonia looks like if you have bilateral infection. But if antibiotics is given, it doesn't go away within 3 to 4 weeks, then you suspect lung cancer. Okay? So give you a little section. This is a section of a normal lung. This is just to get you thoughts going as to what kind of specimens we in pathology or in the laboratory or at a hospital one could get. And it is not difficult to get this material. You just have to ask sometimes. Here is an example of a lung cancer. When you take the lung out, the surgeon takes the lung out, we cut it into slices with a big knife, and this is a nice, peripherally located lung cancer. It's called adenocarcinoma. This is a normal lung. Okay? And this is a cancer lung. You can tell the difference right away. It's very busy. All these glands are present here.
Is the scale the same?
This is more, no, that's a problem. It's not the same. But you can see definitely that the scale is not the same, but you can see that this is probably 2x or 4x, and this is probably 10x, 20x. So it's probably 10 times more, but you can see how much empty spaces is here, and there's no empty spaces here at all. This is all malignant glands. See here? The cells don't look happy at all. They look big and bad, as we call it. Okay? Sometimes I'm showing you very easy cases. Sometimes it's not easy at all. Sometimes the glands are very few, and they I don't know what they are. At that point, you start looking for other things. You start looking at molecular tests. You look for immunohistochemical stains. That's bless you. Yeah.
Could you go back to the location of lung? Wait, the black lung.
The what?
The cancer lung.
Yeah, this one?
So is the white area
Oh, yeah, white area is cancer. The white area is cancer.
So why the other area black?
Why the other area is black? Because that's how lung is. It is brown to black.
Okay.
That's a normal color of the lung.
Okay.
Everybody's lung.
Okay.
Okay? And also, remember, if it's an old individual, when you live, every time you breathe, right, you're taking particles. So you have something called anthracotic pigment that you breathe in. It doesn't get cleared out from the body, and it stays. If you're living in Colorado at 10,000 feet high, not much is going to happen to your lungs. It's going to look really nice and brown. But if you live in LA, 3 years later, this is how it's going to look like, Yeah, I'm just kidding, not 3, probably 10 years, So yeah, it's safe to go to LA, yeah. So Yeah, any other question?
The previous slide was a frozen sample. See, to the untrained eye, they look so much different. I mean, this
Yes.
one, obviously, it's a different color.
Yeah. For an untrained
It's
guy,
frozen, right?
this is not frozen, this is fresh.
So the
And
other
the
one
other-
was fresh. It was-
This is both are fresh.
Why is
Was
one
that
black?
one in Colorado and this one in LA?
Let me check. This probably was Urbana, you know. You see this here, little. You see these lines here? Says Urbana.
Blood drained in this one maybe?
Yeah, I mean not drained. It's. I would say more like, yeah, it's probably blood drain. I would say this one here has more blood to the color. There's a lot more hemorrhage around the tumor. There's a lot more hemorrhage, so you know, it's mixed with blood, you know, in the surrounding. Okay, so yeah.
Is that lung black because of the cancer, or is it black because of smoking?
It is not because of cancer, no. It's not because of cancer. It's because of something that happened to the lung. Okay, it's called anthracotic pigment. Smoking does make the lungs black though. Yeah.
When you're looking at the tissue sample, how much do you know about the patient before you make the diagnosis?
So if before you, ideally, when you look at the slide, it shouldn't really matter what the doctor's going to tell about the patient. You should be able to say it's cancer or not cancer, right?
Yeah, but I mean, like,
But what I do when I look at the case, I get to know a patient's age, they get, you know, patient's sex, I get to know what is the clinical history, was it a lung mass or was it a treated lung mass or, you know, lung cancer, whatever. I can go into medical records and get all the information I need about the patient.
I was asking because we had this discussion about maybe it's darker because of the age or where they live, and that could make a difference in your diagnosis.
Yeah, so for example, sometimes you have like 3 glands, okay? 3 glands that look like cancer, but I'm going to want to get sued, but so I will say, you know what, I don't know what it is. So I go up and look at the x-ray, right? And x-ray shows this big mass there, right? At that point, the 3 glands are malignant to me, okay? But I see these 3 glands, and I look up the x-ray, doesn't look much there. The doctor thinks it's a pneumonia, right? Then I say, you know what? These glands look worrisome to me. It's not diagnosed of cancer yet. You want to do another material, you have to go and do a rebiopsy for it. So it does matter what the clinical history is. Okay, so it does matter. That's why communication is extremely important between the clinicians and the pathologist. Yeah.
Is there a reason why the tumor is white? Is it because there's a
Fibrosis, because there is a tremendous amount of fibrosis, the stroma, fibrotic stroma surrounding the tumor. That's why it's white. Fibrosis is always white. Scarring is always white.
So if you cut into it, will it actually be darker because you'll have more vasculature?
There is a little vasculature right here. This is actually this dark area here. This is actually vasculature. Okay? And it's also white because the tumor is necrotic. When the tumor outgrows its vascular supply, it starts dying. The dead cells looks yellowish white. So that's why it looks yellowish white also. Fibrosis, yellowish white. Okay.
Does it get hard to touch? Like,
Yeah, it gets really hard. Yeah. Here is another case. To a naked eye, it looks very nice, right? So this is normal, and look at this. It's always not dark, you know. You could have like this bronchoalveolar. So this is a different type of cancer. Okay. This is squamous cell carcinoma where you get because of smoking, and I can show you. When you look at endoscopy, like bronchoscopy, we put a little, fiber optic cable and look into your bronchus. You see this little, look at that, big mass here. Lung, again, same thing. And if you look at it, this looks like look at this. Now this one is, look at this lung. It's not that dark, right? But there's a cancer here. You see that? Usually squamous cell carcinoma is white and chalky. See, this is the dark lung with a lot of pigment here. Again, cancer is here. Again, look at this big cancer here. It's all necrotic in the middle. It's falling apart. The tissue is falling apart. That's a lung cancer. So just give you a little visual pictures of what lung cancers. And histologically, when I make sections, I can see all these bad looking tumor cells, a lot of keratin. Keratin is what squamous epithelial cells make. So this is a squamous cell carcinoma. Okay? So those are the things. Some more picture of cancer here. Look at this, cells, they don't look happy at all. They're all malignant cells. There's something called small cell carcinoma, okay? And this is a very aggressive type of tumor that is not related to smoking. And you can see here it causes this big, tumors. And look at this. It's a very aggressive tumor. And when you look at the sections, unlike the other cells, which look kind of glands or little squamous pearls, at different histology, here it just looks blue sheets, all over blue sheets. Okay? So this is a neuroendocrine cancer.
Are these stained specimens for microscopy?
Yes, these are H&E stained, hematoxylin and eosin stained sections. Okay, it's almost lunchtime. It's actually past lunchtime. That's all I can say for now. Do you have any questions?
Are your slides uploaded?
I'll upload them. Okay, I'll upload them.
Thank you very much.
Is that it? Okay. We can talk. You can still ask me questions as we're eating lunch, okay? Make sure there's no food in my mouth.
How do you know which kind of staining you should use for this? Is it a routine or
Which kind of stain you use when?
for diagnostic?
So it's like, how do you know that? That's a very simple question. To answer that question, you'll have to do 4 years of pre-med, 4 years of medical school, and 5 years of residency. And then you need to have 4 years of experience before I can answer you the question. So it comes through a lot of experience. If a robot could do it, then I really will be in trouble. You can make a robot. What stains to order, right? Does it make sense what I asked?
Yes, I mean,
So you asked me. Okay, sorry, yeah. I was like,
So, for example, when you start to do pathology, you stain specific, markers
Yes.
or parts of cell or
yes.
how do you start to?
So basically what we do is we do a H&E first, hematoxylin eosin stain, and that's a random stain. It's a routine stain. So we do the stain and look at it, look at morphologically what it looks like, okay? Some of them look like lymphoma or it can look like carcinoma, right? So I don't know it's a lymphoma or a carcinoma, it's a huge difference. Lymphoma is a good kind of diagnosis. Small cell carcinoma is a bad kind of diagnosis, right? So I would lose the immunohistochemical stains for a lymphocyte marker and a carcinoma marker. So at that point I put both of them on and see which one comes back positive. If you folks are interested, I don't know where you are folks from, go and follow a pathologist in your locality and shadow them for about 2 days. You usually love to have a student around them,
But by the way, you're going to have a chance to visit the lab or something.
Yeah. Yeah.
We were talking about...
Are you not hungry?
No, actually.
Oh, okay.
Hungry for science.
Yeah, hungry for science.
You are saying that there is no screening test for lung cancer. Now, in all the slides that you showed, or at least some of them, you can see the cancer in chest X-ray. Why isn't it at least recommended, even if you were to see only 20% of them? Is the dose of radiation?
Yeah, dose of radiation is high.
Taking one every year?
No, okay. So now, very good question. A screening test is an exam that should be highly sensitive with a very good specificity. Okay? And the risk should far outweigh the benefits. Okay? Just no insult to anybody. If pap smear was done by taking this big forceps and taking this much of tissue out and trying to prevent cervical cancer, to do a pap smear, would you do that? No. Because pap smears are done in a very gentle fashion, the cells are collected in a very efficient manner, it's a good test, great test for screening tests. Now, a chest X-ray is not a very sensitive test. Sensitive meaning they should be able to pick up. If there's 100 cases, you should be able to pick up 100 cases. Yeah.
So my advisor at UAB, he's working on this thing called an optical nose. And the
Optical nodes?
optical nose, like a
Okay,
nose.
optical nose.
So the concept came because there are certain dogs that can sniff someone's breath and determine if they have lung cancer.
Right.
And so he's trying to find a graduate student to work on this project to develop an instrument that can identify the spectrographic fingerprint of the lung cancer like a dog can to determine if someone's breath has the biomarker for lung cancer.
Okay.
What do you think? Is there a certain...
I can tell you one thing. When I go and make a diagnosis, I don't sniff. Okay? I've heard of that dogs can detect cancers and all that. But I know there may be science behind it. There may be something there which I don't know. I can't answer you the question. No.
Okay.
There may be up to something which I don't know.
Okay.
Yeah.
I suggest we continue our discussions over lunch. How about that? Thank you again.